Okay, I hope everybody's back from your a little bit of a quick break, but we're going to go ahead and get started. Um, it is my pleasure to introduce our next speaker, Mallory Sear. Some of you probably remember that Mallory joined us several years ago at one of our summits, mainly presenting about transition to adult health care. And her life experiences have just broadened her impact so much in the last several years. And I knew she would have a lot she could share at today's conference. You probably know that one of the current issues that the Maternal and Child Health Bureau asks states to focus on is health equity. And Mallory will share her lived experiences, including her career in public health and specifically maternal and child health, as she talks about ableism, identity, and equity, a life course perspective. So Mallory, I will hand it off to you.
Thank you so much, Susan. I'm so excited to be back, and I was participating this morning, and so I saw the incredible coin presentation, and that just queued up so much of what I'm going to talk about. And I love how you said, really the theme is where we started and, or how it started, how's it going, because that is really what I'm going to talk about today. We're going to cover some history about transition and a little bit about the work that I've done, but also where do we go from here, and how does the work of MCH and children and youth with special healthcare needs translate into the adult side. And so I'm going to share a lot about my experience with healthcare and just navigating the world in general. We're going to talk about ableism, accessibility, thinking about ableism that we may not even really see in our day-to-day, but that impacts folks, especially related to public health. And then we're kind of just going to talk about some strategies and things that we need to do differently as we move forward. So thank you, Susan, for that incredible introduction. I will give sort of a brief rundown of some of the things that I identify as. I am a public health professional. I am a daughter, a sister, a wife, and a very proud dog mom. And I am a former child with medical complexities, now an adult with medical complexities. I have a rare disease, a digestive disorder called microvillus inclusion disease. And I put a little italics there. I'm not suffering from, I'm not, the victim of, I simply live with it. And I realized over the last couple of years, I often don't even include that in my introduction. And it's not because it's not something I'm proud of. It's not anything I'm trying to hide. And we'll talk more about my disability identity in a little bit. I just forget, because there's so much going on in my life that I'm excited to share. That stuff is just sort of organic for me, and I forget. So I'm starting to be more open and share my diagnosis as part of my identity. I also want to do a quick privilege check and lift up that the experiences that I am sharing are from the perspective of a white, privileged, MPH educated, privately insured woman. Although I do have disabilities, I have a lot of things that have made my experience probably better than it would be for other people. And I want you to keep that in mind, because I am still going to share how it has not been great. And so thinking about it through the lens of somebody who may not be as informed about healthcare navigation, who may not have English as a first language, who may not, come from a white privileged community. There are just so many barriers for everybody, and it's so much worse when you add in other factors. So I just want to be respectful and aware that this is the lens that I am speaking from, and this is my perspective. So when Susan asked me to speak, she said, also, could you give a little life update? And so I did some Googling and I found out that when I last presented was 2013. And we were in person and it was an incredible opportunity. And so I hope one day to be back in person with all of you. But for now, I'm very excited to share some of the things that I've achieved and done since we last met. And I got my MPH. I think when I last spoke, I had just started my MPH journey. My now husband and I had just moved to Boston, which was a whole other transition journey. We did get married in 2018, which was lovely. I was away from MCH for a few years for a few different reasons, but I had the really great experience to work for the state of Colorado's Medicaid program. And I was a contract manager as well as a benefits manager. I worked on our participant directed program for adults on waivers. And then I managed our non-emergency medical transportation benefit, which was quite a feat, but as someone who has used different types of transportation, both state-funded, public transit, across the gamut, I really learned a lot, and I feel like I was able to bring a lot to that position. So tucking my Medicaid skills into my public health backpack, I came back to MCH, and I'm very excited to be here. And I am now in the beautiful city of Denver, Colorado. So I always say, I kept saying when I was doing this transition work, you know, eventually I'm going to have to stop because like transition, you know, eventually I'll be transitioned and transition will be done and I won't have anything to talk about. Well, joke's on me because let it just be known that transition never stops. You know, it's not a one-time thing. So, so as I always talk about in my transition presentations, you know, why is transition important? As a little bit of background, I used to work for the National Center, Got Transition, which I'm sure many of you are aware of. And I really was affiliated with that National Center before it was Got Transition. So we always used to talk about, you know, why is transition important? And as the COIN project queued up so well, is that our kids, our young people with special healthcare needs and disabilities are surviving. And that's the goal. You know, we want them to be adults. We and you all as parents, that is your, you know, your mission to get your kids to be adults and have an amazing quality of life, which Kara talked so magically about, looking at joy and how do we work through this broken system to make sure that our families have joy. And we all know public health has two pieces, right? It has the data side and the narrative side. And that's what it takes to tell the public health story. So I'm very much a storytelling person. So this is going to be a lot of stories and my lived experience. But I wanted to lay the foundation of healthcare transition and show you the numbers and how far we have not come. And talk about, you know, where do we go from here? What are we missing? Why are these numbers not improving? And this is the national performance measure that is measured in the National Survey of Children's Health about young people who are receiving services to transition to adult care. Not great. Still not great. Every year, not great. So we did make some changes. We made some changes in how this is measured. You can see what the question was in 2016, 2017. We're really looking at having that conversation. Did you have a conversation? So then in 2018, the shift was, okay, well, now we're going to look at kids with and without special healthcare needs and make some changes about the way we ask the question. So are you having the conversation about when they're going to need to see a different provider? So overall, whatever changes we're making, we're still not seeing those improvements within healthcare transition. So I'll get more into that and talk about my personal recommendations, some of which I've been shouting from the rooftops for over a decade. But I wanted to lay the foundation and share a little healthcare transition data with you. So one big thing that we hear, or I hear in healthcare transition, and specifically around family and youth engagement, is like, how do we get them to care? How do we get young people to care about their health? And I don't know if you can guess or not, but the WIIFM stands for What's in It for Me. And I want you to think about us as a society. We are so incentive based. You know, would any of you show up to work, you know, if all of a sudden your boss was like, hey, you know, we're taking away your benefits, we're taking away your salary, but like, I'm telling you that this work is really important. You know, you may not believe it, you may be here for other reasons, but we're taking those away, but we still want you to come here and do this every day. And we need to think about healthcare transition and self-management and all of these things. Why is it important to the young person? What do they do in their lives that bring them joy, that is the reason they need to be healthy? And for me, my professional life is very important to me. My personal life is very important to me. I have a very busy, thriving, active life. And for me, you know, I need to be healthy so I can be a good wife, a good public health worker, so I can be a champion for other people. And that is why I need to manage my health. And I will say that as an adult, it's been a lot harder to find that incentive. You know, I sort of have weeded out things that maybe were not as important in terms of my health and my, you know, putting my resources and my days and time and Uber rides and things like that. But we need to look at it from a, you know, families have lives outside of the exam room. What is happening in their life? Why did they want to be healthy? And be willing to have those conversations. This is something that I adopted from one of my former mentors, and I always get a little like foot clamps now when I talk about it because, you know, as someone with a rare disease, my family was told I would not live past the age of 2. And these are just some of the things that I have done in my life. And I always think about, you know, what if we showed families both sides? I mean, obviously in healthcare, we have to be realistic. We have to show, you know, the possibilities and the risks. But what if we also gave hope? And I will say something that's really cool is with social media, I have sort of become something that people find when they Google, you know, the disease that providers are still saying is a death sentence. So we now have a little Facebook group with over 70 families who are still being told that their child is not going to live. So the literature is not catching up with the lived experience. And we need to start combining those narratives because while there may be risks, technology is advancing, medicine is advancing, you know, we are finding ways, families are finding ways, and it's still not trickling down to what providers are telling families. And we need to start sharing both sides of the story. I don't want to get super into like the history of my existence because there's a lot to share, but I never miss an opportunity to share this photo. This is me at my very first dance recital. I was having a lot of bone pain. You cannot probably tell because I was just really excited to be there. I was really determined to do this dance recital. And this is just one example of one of the many things that I was involved in when I was in school. And my family worked really hard to make sure that I was fully integrated when I was growing up. And I don't even know if that's what we knew we were doing at the time. My mom has a background in child development and served as my paraprofessional so that I could go to school and be in the same classes with my peers. But it was constant advocacy. And that was just the beginning of what it would take for me to succeed and be included with my peers growing up. College was another huge transition for me. It was the first time that I really had to identify the natural supports I had had growing up. And when I went on to sort of exist without them, as part of my diagnosis, I am TPN dependent. So I get hooked up to an IV every night. It's a lot of coordination and management. And when I was growing up, we always had a full-time private duty nurse who sort of just made all these things happen. And then once I was in school, I was trying to navigate my social life, my academic life, my medical life. And it got to a point where my health really suffered because I was trying to do it all. And I pushed myself to my breaking point and ended up getting pneumonia, missing half of my first semester. And it was the first time that I really had to assess, like, oh my gosh, like, can you do this? And, you know, my family and I sort of revisited, and also my mental health. I wasn't getting the social interaction I needed. I had a medical single. I felt very isolated. I was devoting all my time to trying to do all the things. And there were just a lot of things where I wasn't happy. I was seeing my friends sort of go off, and this was when Facebook first came out. So all you're seeing is what appears to be other people who are really happy. And that was just the beginning of like, oh, this is really impacting my mental health. And I know that now, but I didn't then. And so this was just a really big time of reflection for me. But what it meant was I went back, reassessed, got the natural or the organic supports. I worked with the health center. I was able to get a nurse to come to my dorm. I moved rooms so I was closer to, you know, my friends and my social circle. And you know, it's all kind of a blur, but I made it happen, and I graduated, and I made the campus more accessible in the process, and I got special recognition at graduation, and it was just a whirlwind. But that was just one of the big transitions for me that I learned, and I grew, and I was like, okay, what's next? The other thing I want to talk about is I have a sister. She's incredible and magical, and I love her very much. And we have the same diagnosis, the same disease. We were born 8 years apart for a lot of reasons. Part of that was providers had very, very strong judgment that they shared very openly with my family about my parents' decision to have another child based on the understanding that there was a high percentage that she would have the same disease, and they didn't agree with that choice. We had her anyway because we knew that our family was not complete. And she is actually this week graduating with her master's of social work, and is also a social justice professional. But what is interesting is we grew up with the same social determinants. We had the same family, we lived in the same house, we had the same teachers, and she had a very negative experience growing up in our community. She was bullied. She does not have the same physical implications of our disability as I do, which is actually a result of medical error. So when she came along, we were very aware of what needed to be done differently. So her outcome was different, but she still needs the same treatment and has the same secondary conditions. But because of the lack of physical implications, people accused her of riding on my coattails. She was treated very differently. And as a result, her mental health really suffered a lot. And it's just, I think, important to share always with public health professionals, because you may see two individuals, two communities, two populations on paper that look the same, but until you hear the stories, you're not going to know. You know, their needs are different, their stories are different, and both are important and both are valid. So we have started being more open about our shared experiences and, what is the same and what is different. And in part of that journey, we have a podcast, which is also sort of a new development. And I will say it has taken a little bit of a hiatus because my sister is in grad school, navigating employment and healthcare. And so when I say, hey, do you want to do a podcast? She's like, I don't have brain space for that. But this has been sort of a COVID project where we start being more open about our experience because we were finding there was not really a venue for us collectively to share our true, authentic voices that didn't fit into MCH or rare disease or, the things that we were sort of doing. And it's gotten sort of more of a following than I think I anticipated. And we love doing it. It's a great opportunity for us to talk to one another and just really share our lived experience and also our experience navigating the world as public health professionals with disabilities. So check it out. There's a QR code that takes you right to our page. I love a good QR code. So I like to share a little bit about, how our family has done what we've done. People always ask me, how are you the way that you are? How did you get here? And I think this is a great platform, and the COIN project really, really spoke great about, families are the ones doing this. Families are the ones navigating these systems. And, one thing I think was really critical in my upbringing was that we were encouraged to transition. We were, given the opportunity to take risks. We were, able to travel and go to school and, swim and go to parties and have friends and have sleepovers. And, but we always understood how to manage our health in that process and how to do things safely. And, I'm sure my mom even now is like, did I want you to move 2,000 miles away in another state and do all these things? No, probably not. But, she let us, and she let us learn our own lesson. And I say she, but my dad is very, very involved in our family. And he is the one who, would put my wheelchair on a merry-go-round and put me on his shoulders at concerts, so I could see. And, he was sort of the risk taker. But we learned, our motto has always been, it's not, no, we can't, but how can we? And we had champions in our lives. We had a wonderful home health nurse who was one of our first providers who would say, oh yeah, you want to go camping? We're going to do it. So we would go camping on TPN, and, we still do. And we are continuing to navigate and find ways to do the things that we want to do. And I think one thing that's really important is, as providers or public health professionals, understanding where a family is at. If they do something a certain way or they're resistant to doing something a certain way, ask why. We do things the way that we do things, and they may not be best practices, which change day to day. But I've been managing my illness, alongside my family for almost 40 years. And I can tell you, whatever I'm doing is working. So I'm not about to try a new gizmo or a new gadget or a new procedure when I have the quality of life that I have. And sometimes that's hard for people to understand. And we'll talk more about that. But this is just a snippet into how our family has existed the way we have. Back to transition. Our children, hopefully, and this is the goal, become adults. And as I've been giving this presentation, it has really evolved because I've started getting immersed in the disability community and disability advocacy, mostly by accident, because I never really identified that way. But what I'm starting to see is that there's a big breakdown between our little bubble of children and youth with special healthcare needs and what then become adults with disabilities or disabled adults. And what I'm finding is that things don't translate. The perception doesn't translate, the programs don't translate, the healthcare doesn't translate, even the language doesn't translate, which I'll talk more about. But I want to share a little bit about my experience. And this is just, I want to say, sort of the Colorado edition that we'll get to, because Boston was a whole other presentation. But it's different on the other side, and I'm starting to be more open about that experience. So let's talk about the truth about transition. So we hear a lot about, what is a successful transition? When should this happen? When should that happen? But there are things that we need to think about. The first one is thinking about cultural components. We in MCH have very narrow definitions of healthcare transition is this. You go to an adult provider and you do this and you follow these steps. And family, we tend to think of family as, and I've seen written definitions where family is a parent of a child with special healthcare needs. Well, I'm not a parent, but I have a family, and it may look different, but we need to start broadening our ideas of what is transition and what is family and what is a family leader, because we're seeing more and more what we may consider non-traditional families, but also our kids with special healthcare needs are growing up. They're having, families, they're having their own, groups of support. And so does that mean I'm not a family leader because I'm not a youth anymore, but I'm not a parent? So where do I fit into this? And people like me who want to have a voice at the table, we need to start reframing our definitions. I highlighted this because I'm seeing a lot where this is not captured appropriately. Transition doesn't happen because we as adults cannot safely be cared for in the adult settings that were not built for us. And I'll talk more about that in a minute. But I'm very sick of seeing, well, youth and family don't try, they're not engaged, they're not planning, they don't prepare. I've had years and years and years of being told in various ways that it's our fault. And it's not our fault because the system doesn't want us. And I'll talk more about that. COVID really changed a lot. You're seeing more people of all ages moving, changing their living situation to be with their natural support. Does that mean that their transition failed? No, it means that they're doing what they need to stay safe in a time of crisis, and that's okay. Again, stop the blame game, look at the systematic barriers, who is missing from the conversation about transition. And we can do all the toolkits and the worksheets and plan and prepare. But if there's nothing on the other side of the bridge to catch us, it gets really frustrating. So this is a very abbreviated version of my very, what I will say, not great Colorado transition. When I was moving to Colorado from Boston, I had my PCP, who is a transition champion in Boston, talk to my transition champion in Colorado, because Colorado and Boston are big transition states. I was like, boom, this is going to be great. I got all the people, I got all the toolkits, I am transition, like, let's do it. So I'm getting ready, we're getting ready to move, and, we're doing our homework, and I get a text from my Colorado contact that said, and I quote, "Nobody is interested." Nobody wanted me. Nobody wanted to care for me as my primary care provider. And I will say, in terms of primary care, I'm not actually that high maintenance. I look pretty complicated on paper, but for primary care, it's mostly just primary care. So, well, guess what? We're coming anyway because I have a job, we have an apartment, it's happening, So we moved here, and I ended up getting connected to primary care after ending up in the ER. due to dehydration, which is a thing about Colorado no one tells you. And we also have this sort of societal blame of people utilizing the ER, and that you're supposed to go to primary care first. Well, guess what? It's not always that easy. So for me, it took ending up in the ER. I got connected to primary care the first time. And I will say I've had 5 or 6 PCPs in almost the 7 years I've lived here. And that number really scares me because patients get a reputation that follows them when providers see that you bounce around, quote unquote. But I will say they've all been in the same system, and some of them were because my insurance changed, or they left because they were a resident and no one told me that. So there were a lot of various reasons, but my first instinct is always like, oh no, people are going to think it's me, which is awful. So then the year of our wedding, I got very, very sick. I ate some bad seafood, which impacted me harder than I think it would have impacted your average person because of my system. And I ended up in the hospital. And the first thing I will say is I went to the ER twice and was sent home with a life-threatening GI bacteria. And the second time I went, I sort of forced the diagnosis myself by asking for certain tests, which they begrudgingly obliged. So I probably wouldn't have gotten as sick as I did if they would have addressed it the first time and tested me thoroughly. When I became inpatient, it was an experience so awful that it's literally physically hard for me to talk about. Because I have never felt so disrespected, so not listened to. And I am a very strong advocate. And for that experience to bring me to tears, think about the people who don't have the skills and abilities and support system that I have. And when I addressed these concerns with multiple people, my PCP, people when I was inpatient, I was told, call a patient representative, and I was given a phone number. Well, when you're sick and you're in the hospital, I didn't have the bandwidth. I mean, as it was, I called the public health department to tell them about my diagnosis so they could track it down and report it. But what I found problematic is that nobody brought that person to me. Nobody made it possible for me to address those concerns. And I still have the note document in my phone because I was trying to track the people that made these comments and, the things that happened and when they happened. And, there were things that happened when, that if I wouldn't have been paying attention and said like, wait a minute, what medication are you coming in with? I can't get that. That's going to make me sicker. If I wouldn't have been able to articulate that, I would have gotten even sicker. And I had a medical student literally deny me antibiotics as a treatment because she wanted to prove that they wouldn't work. And I was like, but can't, like, and I literally, I lost 1/8 of my body weight. Like, I was so ill, and the fluid they were giving me was not, like, it wouldn't have even caught up with my hydration, like, on a good day. And I literally was like wasting away, like just crying and telling them what I needed. And excuse me. And when I finally got discharged, I still ended up being on FMLA, and it took me months. Mind you, this is in July and August, and we're getting married in October. So like, this is like the bridal diet that like nobody asked for. But it was awful. It was horrible. There are still things in my chart I didn't say, which I still have yet to advocate to get removed. So all of this has led to now another issue has popped up that is very specific to my condition. And I wanted to address it before I actually needed, this surgery, which will be inevitable. But having that experience at the adult hospital has made me not want to go back there in a crisis. The thought of it is terrifying for a lot of reasons. So I started this in December, advocating to get connected to someone who can handle this. Long story short, 6 months later, as of yesterday, I had an appointment at Children's Hospital of Colorado, which is the gold standard. And when Colorado says they're a transition champion, a lot of that is because Children's does transition work with young people with medical complexities, and they work across systems, but a lot of people just stay there. And it's well known that the other side is very bad. So it's very disappointing that they were really, really excited to see me, and also not surprised that as a 36-year-old, I was being seen at Children's. They knew why. And that just shows how much work to do. So we have a lot to cover. I'm trying to move forward pretty quick, but I just think this is so, so important to share what families really go through when it comes to transition. Where do we go from here? So I like to be solution oriented. I always say, we can sit on the pity pot, but you have to flush when you're done. So where do we go from here? What are my recommendations? We need to look at why transition is not happening. Like, what happens outside of that one doctor's visit? We are not looking at anything after age 17. When do people transition? Not 17, 18, 21, 26. We're not having the right conversations. Social determinants. Why is transition not happening? I can tell you, sometimes it's a $50 Uber ride for me to go to the doctor. I prioritize when I go, who I see, can I do telehealth? If not, quality of life. COIN is doing so much around quality of life. We need to start translating that to the transition conversation. Educate and incentivize adult providers to take us. No one wants to take us because why should they? We take more time, we take more paperwork, we take more phone calls, and we're not involving adult providers in this conversation of what they need, what they want, to learn about people with disabilities. I've spoken to pediatric residents about disability. I've spoken to other public health classes, and I've heard even in med school, people are saying, oh no, I don't want to work with adults with disabilities. Why would I want to do that? So we're not sexy, we're not fun, we're not pretty, unless we want to be fixed. So we are square pegs trying to fit into this round hole of a system with policies that don't work for us, with providers that don't understand how to communicate with us. And I want to just say, this isn't everybody. I've had some great providers, less so here, and that's unfortunate. But I know that people are trying. I know that it's really hard right now, but it's hard for us too. So let's just come together and figure it out and celebrate that we're here, that we're living. As I said before, my disability identity is complicated. And I'll be honest, I was sort of bullied into identifying as having a disability, which is not how people should come to terms with that. But I ended up meeting my husband at a transition conference in Nevada. He was the youth coordinator for Nevada. I was the youth coordinator for Maine, both with F to F. So send your youth to conferences. You never know what could happen. But he also has a disability, and it really opened my eyes to my own needs and how difficult the world is to navigate for both of us. And I had let my privilege get to the front of that. And he really, changed my narrative and our narrative, and taught me a lot. But I still identify as more than my diagnosis, and I always will. It is a part of me. And I think a big part of that is because I was born with my condition. I don't know anything else. And that is a very different grief cycle than somebody who has an acquired disability, who also have a very strong narrative and presence. Social media has made all of this much more evident and difficult to navigate. We did a podcast episode, highly recommend. But for me, I just incorporate my special healthcare needs as part of who I am. And this process has made me realize how separate chronic illness and special healthcare need land and disability is, and how much work we have to do in that arena. What do I say? What can I say? What can I say? What do I call you? This is a fun little word cloud I made of just words that I have heard in different communities. And I always say, when people ask me, what do I say? What language do I use? I say, which may not be the common response, it depends. Who are you talking to? There are groups that use terminology that I personally don't use. It's not my favorite. Self-advocate, I hear a lot in more developmental disability states. I have seen that used in more tokenizing ways in the work that we do. Crip, advocate, to be, spoonie, wheelie, differently abled. And I also think language depends a lot on, I always say, what service am I trying to access? Like, I will use whatever language I need to get that, to get what I need. But it also is very, very personal. And so I technically, my height is impaired. I don't like that word either. See, words are very hard. But I don't necessarily identify as a little person. I don't have dwarfism. So I think part of my struggle with language is, I don't fit in a box. I never have. But it is okay to say disabled. It's okay to say disability. And what I'm finding, which I found very abruptly through my rebirth on Twitter after a public health conference, is that the disability community, and I say that in a broad way because nobody will ever speak for all people, but there is a conversation emerging now that children with special health care needs is offensive, is not well received, and that we need to start normalizing the discussion around disability, because that is what it becomes. And so our CSHN world is very tiny. People don't even know outside of this work that it's a state program. Like, it's in my title. So I'm trying to sort of navigate having a foot in both ponds, if you will, about how we navigate this. So I just want to lift this up, and I don't have answers. I can't tell you what's right and what's wrong, but I can tell you these conversations are happening, and it's very personal. So some people are okay with saying, what do you want me to use? How do you identify? And I think it's okay to have those conversations from a bigger programmatic standpoint too. I've had our project officers come to me about, we're doing this training, or we're doing a block grant activity, how do we incorporate language in a sensitive way? So just to let you know, this is happening. It's complicated, and it's a bold space to be in. So this is something I've started being able to sort of articulate about my own journey, and sort of realizing why I don't fit into, or feel like I don't fit into, the rare disease and genetic space. I don't want to be fixed. I'm good. I've worked really, really hard. My family's worked really, really hard to have the quality of life that we do. And sometimes providers don't know what to do with that. They're like, well, have you tried? And I'm like, no, I just need you to sign this prescription. Like, I don't need a procedure. I don't want to do your research. And I've actually sort of had some interactions with some researchers who actually got, I will say, combative with me when they said, "Can you imagine a life without TPN?" And I was like, "Nah. Have you ever been on TPN? Do you know what my day-to-day looks like? Like, it's not a big deal." And granted, like, not to say it's without its risks and things like that, but what I will also say is curing my primary diagnosis is not going to make me not 3'9". Like, you want to know what is a barrier? Being 3'9" in a very ableist society. So, you know, the disability community doesn't want to be erased, and the research and medical community kind of doesn't really know what to do with that. So, you know, my advice to providers is provide all, you know, the trajectory of choices and options, and understand, you know, is this going to impair or change my quality of life? Why are you doing it? Are you selling me something? Am I going to get compensated? Like, you know, let's look at what is working and not try to, you know, pull that card from the house of cards when things are good. This was talked about earlier. I always throw this in, and especially around working with youth and thinking about people with disabilities. I, you know, had a whole voc rehab thing when I was in college, and you know, no one really looked at what I already was doing in terms of a career, and but also at the same time, my career sort of snowballed because I was good at, like, speaking and communicating, and I didn't even know what public health was when I got my MPH. But you know, our federal partners were like, "We need you in MCH," and I was like, "Okay, what does that mean?" And I just kept doing things because people told me I should, and I was good at them. And not to say that I'm not incredibly thrilled at where I ended up and, you know, how this is going, because it's going good. But it all happened so fast. I don't always feel like I stopped and thought about, like, what do I want to do? Like, I felt an obligation to continue to do this, to show families and youth what is possible and share my story. But at the same time, I sort of forgot to, like, ask myself what's possible. But I'm happy to be here, and I'm incredibly grateful for my network and, you know, the opportunities that have come up. And but it's been a wild ride, and I just encourage you, as you do this work, to remember that families and youth have interests outside of advocacy, and it can happen really fast. So I want to get into this and talk about ableism and access quickly, and then I'll share some additional resources, and hopefully we have a little bit of time if people don't mind going over. But so ableism is a set of beliefs or practices that basically discriminate against people with disabilities. And like so many other isms, I just want to say this is deeply, deeply embedded in our culture, in our society, and it's not something that people wake up one day and say, "I'm going to be ableist." But there are a lot of things, and I'll share some examples. One big thing about disability is there's the medical model and the social model, and Kara also talked about this. It's almost like we actually didn't plan these, but it queued it up really well. And the medical model basically says that people with disabilities need to be fixed. It's the disability that is the problem. That's why the world is inaccessible. It's inaccessible because we were made wrong. And that if we just cure the disability, that's the solution. The social model looks at the environment and the societal barriers, that if the world was designed differently in a way that worked for everybody, would we really be disabled? You know, so I encourage you to think about, you know, both of those and sort of how you practice and convey things about disability in your work. This is one of my absolute favorite TED Talks. This is Ms. DeLeon, who unfortunately passed away a couple of years ago, but she did a great TED Talk that's in my slides about being an inspiration. And a lot of times you see, you know, marketing or communications or campaigns, especially with kiddos, about, you know, "Oh, you're so inspirational. You know, how do you get up every day? I never could." And I'm like, I'm at the grocery store. Like, I love Trader Joe's too, but like inspirational, I don't know. Accessibility. So accessibility is thinking about the, more around the physical, like access to products and services. And then inclusion, which I didn't include, is more about the policies and sort of day-to-day operations that help people with disabilities do their work or navigate the world. This is a slide that I love, and it's all sort of accessibility fails. And I use this slide when I present to Boston University. So that's the train that we always had to take in Boston. And sometimes we would wait, 3 trains for one that was accessible because they were built in the 40s and haven't been updated. The ramp that doesn't even align with the stairs. I mean, if you Google accessibility fail, like it's just good intentions, I guess. But the elevator one really strikes me because I know, especially in Colorado, everything is about being active and hiking. And in our hospital, when the doors close, it's somebody like at the top of the mountain that's like, we help you live your best life. And it's just like, okay, but like, what are you telling me as someone who takes the elevator? Like, today is the day to take the stairs. Well, no, it's not. Thinking about campaigns like sitting is the new smoking, fitness challenges, all kinds of things that just are those subtle sort of microaggressions. But at the end of the day, like, we're tired. It adds up. Not just physical access, thinking about language, captions, your communications, health literacy, ableist policies that I'll talk more about, and COVID. COVID has illuminated so many inequities that we know have been there for a long time, but it's really brought light to how people with disabilities have been left behind in these conversations and these decisions, especially now that all of a sudden it's like, oh, no restrictions, no masks, no vaccine requirements, and people who are higher risk are being told, oh, well, don't go places. Oh, okay. Well, we'll just go back to those days, I guess. And even subtle things like, the ableism in people that are able to have those human connections, able to just drive to the mountains to get away. Seeing things like outdoor dining put in the accessible parking space, over the curb cut, no curb cut to get to outdoor dining, all of these things that sort of pivoted without thinking about people with disabilities who may be frequenting that also. But what really has been wild to see and really, really disappointing is the healthcare for people with disabilities. We've seen articles about people with disabilities being given forced do not resuscitate orders. Even just recently on Twitter, I saw a man post, I'm a wheelchair user. I went to get routine testing and they asked me 3 times if I was a DNR. Like, does that happen to anybody else? Other people are deciding the value of our lives, which is really, really scary. So what we see, as a result of this and also just COVID, people are not accessing preventative care. Families are not bringing their kids because hospitals are the hub. Thinking about the risk and as providers looking at, what makes sense for these families, is telehealth an option, things like that. So just all kinds of things that are starting to really emerge as a result of COVID, which has been really, really scary. So I pulled this from a really old presentation, but I think it's really relevant because people always ask me, how did you get where you are? How do you do this? How do I do this? How do I be an advocate? How do I be a speaker? Blah, 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 blah. I never stop. On my days off, I'm going to doctor's appointments. I'm working on things like this. I have a 9-to-5 job. I went to grad school. I am advocating with my apartment building for front-loading washer dryer. I am writing letters. I am managing my dog's healthcare. It literally never stops. And so I think those of us who are in it know it, but we make it look easy. And I think sometimes that's part of the problem, but just don't forget, we are successful because transition never stops. Here's some reading. I recently wrote a chapter for a healthcare transition textbook. That's really cool. Some other books about disability. Webinar I encourage you to watch. I kind of shared a little bit about my experience, but if you really want to watch me get raw about healthcare transition, there's links to some webinars, as well as an article I did with another newsletter. Keep in touch. That's my dog. I love to share pictures of her. There's my website, my email, my LinkedIn, my Instagram. You can find me all the places. I really, really appreciate the opportunity. And I know we're sort of at lunch, but I would love to be able to have a few minutes for dialogue. I can see the chat blowing up, but I have not clicked it. So with that, that was a lot of information really fast. I hope people found it helpful, and I'm going to open the chat.
And Mallory, Tammy's going to kind of close this out, but we have till 12:30. So
wonderful. Oh, fantastic. Okay. I'm keeping an eye on my little timer here. So I am opening the chat, but if there are other questions, Susan, or if people want to, I don't know if people are allowed to unmute, but yeah.
There were really some great comments in that chat. And Mallory, would you mind if I just read them? So
yeah, please.
We can kind of share and get some feel for what people learned today. It has been awesome, I have to say. I have enjoyed your session so much. There is I guess we can look at this as a question or a comment, but Matisa, she said, that is my fear of transition. How do we really know when our children should be seen in adult medical settings, especially when they do not present as adults, mentally or physically? What would you think about that, Mallory?
Yeah, it's a really good question and a really difficult one, and one that I think, unfortunately, is really up to us as the patient or the parent. One thing I will say is that, and I have had providers validate this, doctors don't like to say, I don't know, or I can't, or I won't, especially when we're fancy and nifty and different. But I think any sort of documentation or, evidence from other providers, like for me, my example is, I have a central line that I've had for 18 years, and adult interventional radiology said, yes, we are connected to this surgeon at Children's. We will connect you. And it took them, among other referrals from different directions, to say, we're not comfortable doing this. It may be we don't have the equipment, we don't, we don't know how to dose your anesthesia, all things that could be life-threatening. But it's sort of up to us to sort of piece together the systems and the allies to say what makes the most sense. But at the end of the day, I think as parents and patients, we know our bodies best. And if something doesn't feel right to you, like, start having that conversation and figure out who you need in your corner. And like I said, it took me 6 months to even get this appointment. But then when I got there, they were like, hooray, you're here. Like, of course we can do this. And I think another big shift in that specific regard is, for some reason, once you become an adult, this doesn't have to be done surgically, even though not doing it surgically is very, very traumatic. But it's almost like once you become an adult, your emotions and your pain receptors just disappear. But it's like, no, this 100% has to be done this way for this reason. And it's just about being able to like pull that argument together, unfortunately. There is another question from Claire. How can all of us as advocates influence the education and training of adult medical providers to increase knowledge and skills to care for adults who have a condition or a disability that began in childhood? I love this. And I think this is the $1 million question. I will say, start partnering. I know, a lot of us at the state level, or within our work have connections to, lend programs and transition clinics and things like that. I'm still trying to do that. I think having, one keynote speaker a year, is not enough. I know there are like some grand rounds. I just did one at University of Chicago. I've spoken to some medical folks here at the university. But I don't know. I don't know what the in is or how to get it so mainstream. But I think we need to continue to explore opportunities within our states, and continue to lift up what is missing from the transition conversation, because I think what we're seeing in the transition landscape is the same stuff it's been for many, many years. And I've finally taken the bold step to start to be like, what's on the other side though? So I don't know. I think it's also a policy discussion. It's how do we finance those opportunities? How do we compensate providers to want to learn more? CEUs, hourly billing, how do you bill for it? It's such a deeply rooted conversation, but I think we just need to continue to lift up it's something that's missing, because we weren't supposed to be alive and now we're alive. And we're not being considered when the policies are being written, when the curriculum is happening. So I welcome any other suggestions to that question. Let me see. I don't know what's in the Q&A, if there's anything in there too. No, all in the chat, I think. Cool.
Y'all be sure to look at the chat there, and you can see where you can find Mallory's podcast. I can't wait. I love podcasts. So this is the next one on my list. That's there. And
Amy, did you already share Claire's question?
yes.
Okay, I'm sorry.
She just addressed that one.
Okay, sorry.
Let's see.
I'll put my email in there in the chat as well. Sometimes it's easier to just copy and paste things than find a slide. But I love this conversation. I just love being here and being able to share. I think we learn a bunch of stuff in public health school, but I honestly probably don't remember like 80% of it because I was too busy surviving. But what I learned was what I learned through surviving, which I think we all can speak to. Yes, Susan, are you going to be sharing, or Susan or Tammy, are people going to be receiving the slides?
I'm not sure.
Are you asking about the copies of the slides? I see Jenny did. Yes, we'll be sending those out, but they're also available on the website.
Oh, perfect.
And Drew, maybe you can drop the link in there. There we go.
Quick.
Look at it, Drew at the ready.
Mm-hmm.
Love a techie helper. Any other thoughts or questions? There's a lot of just great feedback about,
There is.
this is the reality and people's experiences. And one thing I will say is when I presented on that webinar, it was sort of the first time that I just got like really authentic, and I sort of didn't really like expect it to happen the way it did. And I was a little bit nervous because it was a provider heavy group. But what I saw in the chat was exactly this, and families coming forward and saying like, this has been my experience. You're total, like, I'm sorry this happened, but I'm not surprised. Like I share this, and it was just really validating, and also just so disappointing that we've been doing this work and pouring so many resources into transition, and people are still having this experience, and also just general quality improvement of healthcare, because I feel like we're literally just going back in time, and I don't know how that happened. I know everyone's burned out. I know places are understaffed, and but
I think we need to pass the torch while we're still here as active folks. that we need to be training and sharing our knowledge with those that are coming right up behind us on our heels, because I really am passionate about feeling that same thing you just said, Mallory. We keep repeating history, it seems.
Mm-hmm.
And maybe if we were, while we were still in the heat of it, that we would share that with the others that are maybe 10 years younger than us or whatever, to think of some algorithm to solve it all.
Well, and it's, that's where the youth engagement piece comes in too, because it's like, how are we training our young people to be, the future leaders in public health and in systems improvement, in government, and thinking about that, we were told, we wouldn't live. And now both my sister and I are working on improving the system we grew up in. And she's actually speaking this fall at a vascular access conference, which the invitation came up because she had a really, really negative experience with a provider and they learned together and he learned from her. And now they're sort of taking the show on the road. And it was her experience that made me start navigating for when I need that procedure done, making sure that it can be done a different way. And so she and I sort of continue to go back and forth and learn from each other, and educate others. So I think it's also, about that empowerment of people with lived experience at a systems level, and the trajectory from tokenism to how are we really, really involved in shaping those policies. And when I was in the hospital, I was saying, I work in policy, I pay your claims, I understand, but there has to be a workaround for people that this doesn't work for. Like I was not allowed to use my own medication or heparin flush because they physically could not get me what I needed. But in telling me that, they weren't giving me an alternative. So when they saw me using my own, which I said, you have an opportunity to get it, or I'm going to have to use my own, they actually reprimanded me. And there are now things in my chart that say I won't access my own medical device, which I never agreed to. So by the time I left, I was flushing my sterile catheter in the bathroom like a criminal.
Wow.
Yeah. So that's just one example. And if I hadn't used my own, I would have then needed surgery because my line would have clotted. So for them not to find an alternative solution, I had to find my own, and then was penalized for finding my own. And that's still in my chart today. So there's a lot of work to do. Yeah, for sure.
Yes. Does anyone have any more questions? Throw it up in the chat real quick, and Mallory's glad to address those. Let's see here. Okay. Well, if here's one. You say that, Mallory?
Have I been able to work with a hospital? So, I will say I have not taken strong advocacy action yet, beyond talking to my PCP and my other providers and saying that this is the case and asking for, support in, getting that removed and changing it. And I'll be honest, I have not had the emotional capacity. I haven't even started really reliving this experience until recently. And I know that I need to sit down and document it. And I know it's probably too late for some of these issues or these people. But basically I need to put on my big girl advocacy pants and write everything down and file a complaint, because it is the hospital that I would have to go back to, or would probably go back to, which is a whole other decision I need to make. But no, and I take partial responsibility for that, but also it upsets me that nobody in that moment gave me an avenue to do that. So that now 4 years later, I'm finally processing the trauma, and they're going to go, why are you waiting till, like now? I'm like, because I have other things to do. I have a list of letters I need to write, and that's part of, I think what frustrates me too, is that it's on us. Like, it's on us to advocate, and I totally get it. Like, I'm an advocate, but when I'm sobbing on the phone to my parents and the doctor walks in, and when I'm shouting, they're not listening to me, something is wrong. Like, you obviously need to get somebody else involved. And I find it frustrating that nobody was willing to do that on my behalf. But maybe I have very high expectations, I'm realizing. Susan wrote a really good question. Has Owen's experience been similar or different? So one thing that's very interesting, which I would love to research down the road if I were ever a researchy person. So Owen goes to Denver Health, which is what we would consider the safety net hospital. So they take Medicaid, and they can't turn you away, basically. And his care has been great. And I will say he has sort of less, he hasn't been an inpatient, knock on wood, but he's access specialist. He's gotten primary care there since we moved here. And what I think is interesting is when we lived in Boston, we got primary care at the safety net hospital, and I got specialty care at the bougie, expensive teaching hospital. And it's night and day. And that's what we've seen in Colorado. And I'm starting to get a little disgruntled about the fact that medically complex individuals are automatically referred to the bougie, expensive teaching hospitals because they're the quote unquote best. I don't know that they're the quote unquote best. I think that they want us for different reasons, but then when it comes to actually caring for us, it's a whole other ballgame. So I would love to learn more about patient satisfaction with safety net hospitals versus university teaching hospitals, because I personally have seen just a really big difference. And when we got primary care at the safety net hospital in Boston, I mean, our primary care provider would come in on a day that worked for both me and Owen, so she could see us back to back, because she knew transportation was an issue. Like, certain things where they just have a bigger understanding of like the social determinants. But I find that really interesting. And, part of why I'm so like reluctant to like just jump systems, as I'm sure you all understand, is like now all my stuff is in one portal. So, it's like I understand the system. I get what I need. It's like, and now it like kind of works with children. But is it worth like starting over? Because I do finally have like a PCP I like, a GI specialist I like, who I see once a year. She's willing to do telehealth. My new PCP is like 3 blocks from my house, which no one felt the need to tell me existed when I was going 45 minutes to the hospital. So I don't, it's very difficult. Like, there are a lot of hospitals, not as many as there are in Boston, but I've talked to my transition champion here, and she's like, no, you're where you're supposed to be. And I'm like, am I? Have you been here though? So I don't know, he's had a different experience. He's had a positive one, and I'm very grateful for that. So I don't know. And yes, Sharon, yes, my friend, you just honestly get tired of the fight. I had no fight left in me. And to bring all of that back up and try to fight again, I know I need to, even if it just goes in my chart. But I haven't had the bandwidth. I'm too busy living and surviving and doing this, so other people don't experience what I experienced. But I'll get there. I'll do it because it needs to be done. But yes, my friend, you hit the nail on the head. Virginia also said, this is a fear a lot of us have for our patients, and would love to help take the burden off patients and families if we can. We love you, Virginia. We support that. And I think the fact that there are events like this, and I will say my speaking roster has been so full this year and last year And as much as I would love to be with you all in person, I think it's made it easier to speak to more people in a shorter period of time. And I've had a lot of interest from like hospitals and medical schools and public health schools. And so I will also, put out to you, if you are interested in having me come and share some of this with your medical folks, your public health folks, or other people that would be interested. On my website, there's a speaker interest form that you can just fill out if you have an event coming up and you're really interested in me being involved. I would be happy to entertain those requests, in person or virtual at this point.
Hey, everybody, it's me over here.
Hi,
Mallory,
Jamie.
you've been
Thank
awesome. I was talking to my coworker who's next door about this last week, and this was a session I was really excited about. And then Susan asked me, just to kind of do the little thank you at the end. And I'm glad I got this one. I really learned so much, and I unlearned some stuff too. Unlearning maybe some preconceived ideas, even as a mom who has a daughter with a very rare syndrome. And then too, I feel like you reinforced a lot of things I've been passionate about forever too. So I learned, I unlearned, I relearned. It's been great. It's been really good. And I feel like everybody would echo that. You've been an excellent speaker. And it's hearing that story, that lived experience, that really, I think, brings out the passion in all of us when we hear those stories. And when we've actually lived some of it, some of us ourselves have lived very similar things. But is there any more questions? Let's look at this. What does this say? I didn't see that. It's Claire. As a member of our hospital ethics committee, I learned that part of HIPAA is not only the right to see what it's in your or your child's chart, but to refute things that are not accurate. I have had to, unfortunately, advise families of this a couple of times. So, thanks, Claire.
Yeah, that's actually important to know. And, I think, that's just an example of like anytime you can have a policy to back what you are asking for or advocating for, that is really beneficial to me. I actually didn't know that. So I appreciate you sharing that, and I will share that with folks as well.
Something we all need to know, truly.
Oh, the little graphic thing. Can I get a copy of that?
Yes, we will share the like polished up copy with everybody afterwards. Because there's the little dancer over on the left.
And look, there's a little picture of you over here. Yeah, that's so cool with your little jacket.
Oh, I love it. Oh, this has been wonderful. Thank you so much for having me.